everybody, welcome. I'm Chenel Trevellini with Patient Safety Solutions, and I have Nora Sammon here today, interviewing her as a CWOCN, CWON, but WOCN Certification Board Certified Nurse.
Correct.
And we are going to talk about her role. I have some fun questions today, and I hope that this will be a nice, carefree little interview, and we'll get to learn a little bit more about you and your role.
I'm very excited to be here, and I admire my friend Chenel here, so I'm very excited to have her do the interviewing.
Ooh, great. Okay. The first thing I want to ask you is, what pathway did you take to become a WOC nurse?
So I was educational. So I started off at the Cleveland Clinic, and
Wow.
the birthplace of our profession.
Yes.
And I started as a nursing assistant there, but worked my way up, and my mom was a WOCN, and so that's how I was inspired to do this job. And since I was already working there, it was a great transition into it, and I did all my clinicals at the Cleveland Clinic as well as the educational program, and so yeah.
And that's fantastic. And I believe, if my memory serves me correctly, you're a second degree nursing student. Like you had a different degree before.
I started, yeah. So I started off actually wanting to go in education, and I actually wanted to teach music. That's my first area. And then I actually worked full time as I put myself through school, and eventually, because my mom worked at the Cleveland Clinic, I was able to easily, kind of get familiarized with that as my new workplace. But I never actually got the degree. I just worked very long to get the nursing degree.
Okay.
It took me over 10 years, so
Yeah.
it was a struggle.
So we're going off script here, but I do have a different question that I want to ask you. How did you get from Cleveland Clinic to Mount Sinai St. Luke's?
Such a romantic story. Not really, but so that I worked at the Cleveland Clinic for about 12 years, and I was in my 30s, and I said, if I don't do something different now in my life, I probably won't do it. And I was looking for a change. And because of the way the Cleveland Clinic was designed, with the wounds being a different department than the ostomy, I kind of wanted to see again where other avenues in my life would take me as far as combining the two. And there was, it actually took me to Cornell, New York Presbyterian.
Okay.
And I have to actually give props to my friend Roxanne Elling, who was a student I precepted, and that's how I met her. And she's the one who I tell her she's the golden girl, because everything she recommends that I do works out beautifully. So she said, would you ever be interested in coming to New York, where she is from? And I said, girl, I can't even see myself there, but then I did, and I started picturing myself in the exciting city of New York, and I followed that, and it led me to Cornell, New York Presbyterian Cornell, which they actually needed help in starting an ostomy program there. So I let the doors open, and I went through, and there I am.
Very nice. And now you find yourself at St. Luke's, part of Mount Sinai Health System.
That is correct.
So that's very exciting.
Yeah. And the way I came here was they obviously needed someone. They did not have a WSN here for a couple of months, and and I think the fact that I worked at Cleveland Clinic had a big sort of push for me to come here. I think that was a big leverage, so to speak. And I think also for the length of time that I've been working in the field. So
yeah, they're very lucky to have you.
Well, thank you, my friend.
I still remember the first time we met in your sparkly Cinderella shoes.
Oh yes! Oh my gosh!
That was a fun day.
Yes.
Okay, so next I just want to ask you, have you noticed any new and emerging trends as a WOC nurse? Since maybe even thinking back to what it was like when you were a WOC nurse back at Cleveland Clinic, and how things have changed now.
Absolutely.
And share some of that with us.
Well, I like to think that we ourselves change our own, elevate our profession, right?
Yes.
So I think we have to be our own best advocates, not only just letting people know who we are and what we do, because people really don't. First of all, I think I have 20 bosses out there who tell me what to do, but I think once they understand the vastness of my responsibilities, there's a little bit more respect and appreciation. But the emerging trends that I see, I think, have a lot to do with a combination. So patients are nowadays don't just have one disease come in and then we fix that and then they're off and on their way. They have multiple comorbidities, and multiple problems. Someone might come in and they have an ostomy along with a wound. You see wounds that are so much more drastic and more of a deterioration on a patient, and it's hard to believe that because we have so many more technologies nowadays that can help fix these patients a lot quicker if we can work together in that way, right? So if we get the right nutrition on board, if we, make sure that they're having some type of mobility, even if they're paraplegic, are they moving their upper body, are they getting oxygen to these wounds to help heal them? And then obviously also combining that with our knowledge of our wound care products, right? So, but I do think emerging trends might be a lot of moisture associated damages out there.
Yeah.
And that is a, I always say that's the top to the bottom problem, but then you have your pressure, which is your bottom to the top, and you put those two together, and it's a very difficult situation often for patients. So,
so we have a lot of problems with not only with incontinence, but also now that we are not using indwelling urinary catheters as often because we're trying to prevent catheter-associated urinary tract infections. And then a lot of our antibiotics that we have to give our patients, they cause a lot of diarrhea, and so then you have that combination of that urine and stool, and then them sweating.
I was just going to say, that's underappreciated moisture, isn't it?
Really is.
We had two patients, one male, one female, that were admitted within a month of each other, actually, who had long stays over a month long here. And they came in and they had ARDS, and they had to be proned, and they were overweight, they were obese, and so we couldn't get them onto a bariatric bed, and that was a challenge, but they were both constipated when they came in, so they weren't functioning that for a while, and then they both had catheters that were inserted. So really, their moisture associated started with their sweat and their weight and all of that, and their fevers that gave them persistent moisture down below.
Yeah, and they probably had a lot of problems with intertriginous dermatitis, with the skin folds, and
and we actually helped prevent that from getting worse by identifying that pretty quickly. They just couldn't be turned, so that was another big challenge. And I think having the doctors and getting a team effort in prevention of this sort of situation really is helpful, and that's been quite a challenge, I think, and them I think they're very sort of set in their ways of how they manage situations like this, right? So not understanding a microturn and what a microturn is, and now that we have the products here to help with that would be something even little that we could have done maybe. But and they both developed unstageable pressure injuries, which developed to stage 3s on both of them, and hopefully no deeper than that at this point, but they're both still here,
So based on those emerging trends and patterns, how do you see your WOC nursing role evolving?
Well, it's a big world here at our 495 bed hospital place here, but I came from an over 1,100 place at the Cleveland Clinic, which had a far greater team, which you have to really, I really think inspiring nurses to want to do this and want to prevent. They're so busy, and I think our nurses today have become very task oriented, and I was brought up in a world of deep critical thinking, and it was beat into my head in a loving way. And I like to say, and I like to promote our profession, that I feel like we save lives one wound and ostomy at a time, and I really think you'd see that you really need to involve the family. You really need to explain, and they truly appreciate your impact on their families' lives, and even the patient themselves appreciates you in affecting their lives in a very positive way. And what I really can appreciate after being here, it'll be 2 years in August, that my CMO has demonstrated and publicly acknowledged me and how much impact I've had in this hospital at what we call the bridge presentation that I do, that we are asked to do periodically to show difficulties that we're having in our area, but then you see the impact of the good stuff that you have done, especially in a team effort. And so inspiring nurses to want to then prevent pressure injuries and make that a difference in their lives, but also to know that this that's what I love about WOCN care, is that it's a very nurse-driven area versus medical, right? So, you can make a lot of changes very simply, like a turn is a simple thing, but how do we do that turn, and are we doing it effectively? How are we offloading our patients, and are we using good devices? But if we can't, can we use something else if they can't afford it, and also make sure the patients go home with what they have here to continue that as they work home and hopefully get better there as well. So it's the continuity of care, and working with your case managers and your social workers and the whole team effort, So the role has really probably evolved, and it's a leadership.
It's more of a leadership role, and I think I'm seeing that, and not only in the experience that I've had in hospitals, but also whenever we go to conferences and we hear different lectures, and we really see that it's important for that WOC nurse to have that leadership role. And it'd be nice to start seeing some chief nursing officers have that WOC nurse certification.
Oh, girl, you're giving me goosebumps here as far as that goes. But yeah, that would be great. I think, and with respect to the leadership role too, I think is the educational aspect of it as well, right? So it's the combination of that, and again, with trying to inspire nurses in like whether it's even management, getting them involved, you cannot change a culture without the management buy-in, and that is a very difficult part of it, because I think also with CMOs and CNOs is that we aren't your money makers, right? We don't come in and give someone a new heart per se, but we make that heart beat a lot better by what we do, and we help the heart of the patient, not just the physical heart, but the literal, the figurative hearts, so I think that's got to be appreciated as well. And I think they see that we do save a lot of money too by what we do, so we prevent a lot of deterioration and further issues and lawsuits and a breakdown of the patient, and you look at your patient and everything needs to work together. You can't have a heart without, hello, your skin is your first organ you visually see, and until you bring out intestines, you don't realize and appreciate their work and how they help and feed everything in the body, and everything works together. And we have to use that team, as the body's a team of itself, that we have to use that team together out here in the world to prevent and fix issues.
Yeah, very well said.
Thank you, my friend.
So the last question I'm going to leave you with today is, if you had a magic wand and you could use this magic wand to change anything in your practice that would really help maximize your role as a WOC nurse, what would you do with that magic wand?
Well, I'd take that magic wand and I'd hit everybody gently on the head, so I wouldn't cause any pressure injuries in that way. But no, I probably to help the public understand, number one, what's going on and what they need to do when they come in here, and the risk of a pressure injury, right? And two, because I do rounds in the ED and trying to start it where it begins, often in there, but to have the public and to get more advertisement, I guess, out there in the world, whether it's in TV, and even bring it into story. So I'm working on a fictional novel about nursing, and yes, I am in my not very much free time, but I like to have that understanding and what we do, and then to carry it through into the public, but also with doctors. I think, you think that this would be something they focus on in medical school, and it's so surprising how little of it is focused, again, being the skin, the largest organ on the body, It is
surprising.
And how little they know about wounds and wound care and the destruction of the skin and the layers of the skin and how each is impacted by my drugs that they're ordering or procedures these patients are in, if they're in the OR for longer than 3 hours, how that increases the risk. So a whole, plethora. But I would want to take that magic wand and make everybody just love the work that I think that we're doing, but that they also have a role in that, and to appreciate that.
That was very well put. I really like that.
Thank you, Chenel.
So
Number 5.
I just want to tell you that I really appreciate you taking the time to let me interview you today and to let me be a guest in your hospital.
Please.
And I just really appreciate it from the bottom of my heart.
Well, I love you, Chenel, and I love the work you do, and the fact that you are an entrepreneur with this, and that is something I've always wanted to start my own business with, wound and ostomy. And I wish they would do more of that at conference, and I really wish they would have more people that are in some sort of entrepreneurial role bring that to us and help teach us how to do that better. And you're a definite example for that, so thank you.
Thank you.
Yes. Can I get a hug?
Yes.
Okay.
So we thank you for tuning in, and you can catch more of my blogs and vlogs on patientsafetysolutions.net.
Thank you.
Till next time. Bye-bye.